let's jump in. Approach to acid-base abnormalities. Approach to acid-base abnormalities. No, usually when we are starting these topics, so that you will understand why we are doing what we are doing and why I am focusing on specific topics, you realize that the rationale for this particular objective is abnormally high or low hydrogen ion concentration, okay? Abnormally high or low hydrogen ion concentration, that is acidemia or alkalemia respectively, is encountered relatively frequently and particularly in hospital-based. Okay, and don't forget that your exam, you are going to be quizzed on acute medicine, chronic medicine, okay? And when I say acute medicine, I also want to share this with you so that you'll be able to appreciate it very, very well. Why are we dealing with, acute stuff? Because in the MCCQE1 exam, the way they've weighted the exam, okay? Let me show you the screen again so that you understand why we do certain things in MedCognito. If you look at the way they've weighted the exam, okay, you will understand something very simple. Number one, you will see that this is like the percentage of questions which should appear. And if you look here, dimensions of care, you are expected to see more acute cases than any other group of cases. And when you talk about more acute cases, you are talking about emergency medicine situations, right? Now, when you also come to the physician activities which are tested, you realize that assessment and diagnosis is the highest. So, for example, if you're dealing with acid-base abnormalities, okay, where should I place my emphasis on when I'm teaching my candidates? Number one, I have to go acute medicine. So, how to identify, all these crazy acid-base abnormalities, and then how am I going to assess if this patient has metabolic acidosis, if the patient has metabolic alkalosis, those kinds of things. So that is why we are doing that. So this shows you, the percentage weight that they put. So, for example, if you are learning acid-base abnormalities, you are expected to see more questions on how to identify. Is this metabolic acidosis? Is this metabolic alkalosis? Is this respiratory alkalosis? Is this respiratory acidosis? And then the next weight will be, how am I going to manage metabolic acidosis? How am I going to manage metabolic alkalosis? How am I going to manage respiratory acidosis? How am I going to manage respiratory alkalosis? Okay. Then you realize that, well, you may not really need to learn so much about communication so far as acid-base balance is concerned. But hey, maybe especially for those who are going for the narcosis, right? Okay. And then professional behaviors is like ethical concepts in relation to acid-base abnormalities. But from your experience, you realize that what you need more is how to assess a patient with acid-base abnormalities and how to manage them. And then if you come to the dimensions of care, most of the time, acid-base abnormalities occur in the emergency medicine setting, the acute setting. Okay. So if you go back to the objective that I was sharing, it says abnormally high or low hydrogen ions. Okay. Abnormally high or low hydrogen ions, ion concentration like acidemia or alkalemia respectively, is encountered relatively frequently, particularly in hospital-based practice. That is acute care, right? Acidemia may be caused by an underlying life-threatening condition. And remember that I said that in the MCQ1 exam, they are basically looking out for how you're able to keep patients alive. And that is why even when you are listing your answers in CDM, I've always encouraged that list those things which will kill the patient first. So for example, if you have a patient with abdominal pain, yes, dyspepsia is important. Yes, irritable bowel syndrome is important. But you have a patient with abdominal pain and, you need to list diagnosis, please go in for those ones which will kill, like appendicitis, like intestinal obstruction, like intestinal perforation. Go in for those ones first. So that's the same thing we are going to do with acid-base abnormalities as well. Several acid-base abnormalities can coexist in a single patient. All right, now let's move on. Now, I need you to write this down because this is one of the very few objectives that The medical council just gave you free information, said that you don't have to worry and go to look into books to study. So this is what I mean. Metabolic acidosis. If you get a patient with metabolic acidosis, just ask yourself, what are the types of metabolic acidosis? We have high anion gap metabolic acidosis and normal anion gap metabolic acidosis. This is from the Medical Council of Canada itself, okay? Their objectives. This is what I'm saying. If I were you, I'll write metabolic acidosis, high anion gap metabolic acidosis. What are the causes? A patient who takes methanol, a patient who has ketoacidosis. So high anion gap metabolic acidosis, what are they? And patients who have kidney impairment, so like kidney injury. Now, this is not the focus of the class today, because before we even get here, we need to get the basics right. But I'm taking you through the objectives. That is why I'm just, reading this out to you. Now, you also have under metabolic acidosis, you also have normal anion gap metabolic acidosis. And the causes of those can be, patients with diarrhea, gastrointestinal loss of bicarbonate, patients who have renal bicarbonate loss like renal tubular acidosis and interstitial nephritis. Okay, good. And then we also go to metabolic alkalosis. Metabolic alkalosis, basically, what are the causes? Patients who take excessive mineralocorticoids, okay? Patients who have been vomiting, because usually in the stomach you have hydrochloric acid, right? So if you vomit, the acid can go away and then you can develop, an alkalotic state. And then exogenous ingestion. And then we go to respiratory acidosis, cases like subarachnoid hemorrhage, drugs like salicylates or aspirin, miscellaneous causes like fever, pain, pregnancy. Okay, so for these causes, you can just write them down. But today, we're going to jump into the key objective, because the key objective is what will help us to be able to appreciate those objectives which are up there. Now, given a candidate with acid-base abnormality, the candidate will diagnose the cause, the severity, and the complications, and will initiate an appropriate management plan, particularly when dealing with a high anion gap metabolic acidosis. That is one thing I want you to write down. I'm going to revise high anion gap metabolic acidosis. Please write that down right now before we move on. High anion gap metabolic acidosis. High anion gap metabolic acidosis. With all these things I'm learning, one topic I'm going to make sure that I don't miss is high anion gap metabolic acidosis. Now, with the causes that we elaborated, who can remember or who can mention like 2 causes of high anion gap metabolic acidosis that the Medical Council made mention of when we're talking about those causes up there? Who remembers? Who can help us?
Methanol.
And what else?
Ethylene glycol.
Metabolic acidosis and then ethylene glycol. Beautiful. So please, if so now you see what we are doing here. I'm going to learn acid-base abnormalities, but if I even forget everything, when it comes to high anion gap metabolic acidosis, I should not forget that. And what are some of the causes of high anion gap metabolic acidosis? Number 1, methanol. Number 2, ethylene glycol. Number 3, diabetic ketoacidosis. So when I'm done with this class, what I want you to do is just go quickly, 2 lines, methanol poisoning. How does the patient appear? Ethylene glycol poisoning. How does the patient appear? Diabetic ketoacidosis. How does the patient appear? Now, for those in MedCognito, we've already done all that work for you. It's in your portal. Okay? But those who are not in the course, if you want to do it, these are the topics I want you to review. Methanol overdose, ethylene glycol overdose, metabolic diabetic ketoacidosis, because these are common causes of high anion gap metabolic acidosis. Now, the enabling objectives. Given a patient with acid-base abnormality, the candidate will, number 1, through efficient and focused data gathering, okay, diagnose the cause of acidemia or alkalemia expeditiously. That is data gathering. So as soon as you see a case and I'm telling you that the patient is comatose, the patient is on the ventilator. From what we are going to learn today, it should tell you the kind of abnormality you may get. If I should tell you somebody comes in, 16-year-old girl comes to the ER, she's afraid that somebody's about to take her life, and she's breathing quickly, and she's anxious, you should know. If I should tell you a non-diabetic with, a serum glucose level of 43, the patient has small breathing, you should know. So that is what this particular objective is talking about. Now, list and interpret critical, clinical, and laboratory findings that are key in the processes of exclusion, differentiation, and diagnosis, including those derived from, number one, an accurate arterial blood gas analysis. This is where a lot of candidates start shaking. Hey, Dr. Broni, I don't know what to do. And this is what we are going to break today. Today, we are going to break that jinx of, the fear of, properly assessing arterial blood gases so far as acid-base balances are concerned. And then complementary investigations for acidemia or alkalemia aimed at identifying the primary abnormality and the adequacy of the associated secondary compensation. Today, we will not focus on secondary compensation yet, because I want us to make sure that we grab this well. And if you grab this well, you've grabbed 80% of acid-base abnormalities. Okay, good. The next point is construct an effective initial management plan for acidemia or alkalemia, including describing general supportive measures. Number two, describing management for specific acid-base abnormalities. And the top three I mentioned, based on the fact that you should know high anion gap metabolic acidosis were methanol. So before you finish this, if somebody comes to your ER with methanol poisoning, question is, how do you manage? Ethylene glycol poisoning, how do you manage? Diabetic ketoacidosis, you know that you're going to get a patient on a high acuity bed. You're going to manage their airway, their breathing, their circulation. First step in diabetic ketoacidosis management, you're going to give them fluid, normal saline. You draw your blood, and the key blood sample you are looking for is potassium level. You are not going to give any insulin until potassium levels come up. If you get potassium levels, is the potassium high? Is the potassium normal? Is the potassium low? Because if you give insulin before you give potassium, and the potassium level is already low, what you can do is to tip the patient into cardiac arrest. These are the things the medical council wants to see. The way you think about these cases like that, diabetic ketoacidosis, I admit, high acuity bed, I give my fluids, I wait for lab to bring me potassium levels. While I'm waiting for labs, I'm just giving fluids, right? As soon as I get my labs and I start correcting potassium, if potassium is above, say, 5.3, I'll hold on with giving potassium. If potassium is in the normal range, I may just give about 20 millimole per liter of potassium. If potassium is very, very low, then I want to give about 40 units, just to bring it up. It is when I start correcting potassium levels that I will start giving my I'll start giving my insulin, right? And then how you titrate insulin down till you get around 13, where you switch from normal saline to dextrose normal saline, kind of thing. But today we are not going to go there. I'm just giving you a gist that when you are learning this, the management principles you should start thinking about are ethylene glycol, methanol, diabetic ketoacidosis. Those, if you can even manage those three, it should be good. So in class today, we'll focus on the toughest part to make it simpler. And the toughest part is even identifying right from the word go. Is this patient metabolically acidotic? Is this patient metabolically alkalotic? Is this patient in respiratory acidosis? Is this patient in respiratory alkalosis? Because as soon as we get that, the rest of the management becomes very simple.